Good morning. I am Dr. Rajendra Prasad. Currently, I am a Director Medical Education, ERAS LUCKNOW Medical College and Hospital, Lucknow. I am also heading the Department of Pulmonary Medicine here. I have been former Director, VALLABH PATEL Chest Institute, Delhi, and I have also served King George Medical University for last 4 decades as a pulmonologist. Today, I am starting with a new series of my lectures that is Interesting Pearls in Pulmonary Medicine. It will be divided into 4 parts. So, what I will be doing in part 1, whatever cases I have seen in last 4 decades of my career as a pulmonologist, some of interesting pearls I am going to share with you. I am starting with the first case. There is a middle-aged lady who was referred to me for this shadow in the right lower zone, which you can see. But then when I examined her, I found nothing in the physical examination. That gave me some doubt what this shadow could be. So, then I got a lateral view done, and ideally this shadow should have been located either in the middle lobe or in the lower lobe, but lateral view had shown no abnormality. So, in fact, when I examine the patient, so you find that there is a carcinomatous breast. So, this breast, carcinomatous breast, is causing this shadow. What I am trying to say that not that every shadow visible in the X-ray may be because of the chest lesion. There are extrathoracic shadow which may cast into lung and create confusion in the minds of chest physician. The another lady, young lady, when she came to me, she had no complaints, but her only problem was that some doctor who saw him before me had started anti-tuberculosis drug based on this X-ray. If you see the X-ray carefully, there is a homogeneous shadow in the left upper zone, but as lady had no symptoms, so that has prompted me to investigate her further. So, what I could find in the chest X-ray, that origin of this shadow I could trace outside the confines of the chest wall. In my previous lecture, I have told that any shadow, if it is coming, if its origin can be traced outside the chest wall, most probably it is an extrathoracic shadow. Actually, her hairs were very beautiful and she has pleat, and when I suspected that this could be because of the pleat of hair, when we got another X-ray done removing that pleat in front of her, so that shadow has cleared. So, when I got X-ray repeated on the same day when we have disturbed her hairs, and then I found that shadows had disappeared. So, this was a pleat of hairs causing the shadow. This is again an extrathoracic. I mean, something coming from outside may cast a shadow on the chest X-ray. Here you can see very clearly that if something is coming out from outside and then causing a shadow in the left upper zone, this is a classical example of extrathoracic shadows. This is another lady which was referred to me in 1985 with some small rounded opacity in the left lower zone as a suspected case of a solitary pulmonary nodule, suspected as a lung cancer. And when examined the patient, I found nothing in the examination. So, what we did, we just got X-ray repeated we have strapped the breast with some cotton and then that shadow got disappeared. So, what I am trying to say, this was a nipple shadow casting as a solitary pulmonary nodule. So, chest physician has to be very careful while seeing such type of shadows, and one has to use his common sense to find out what this shadow because of. So, it was a nipple shadow causing a shadow like solitary pulmonary nodule. Another important issue I always tell, when there is a costal cartilage calcification, I have seen this gentleman, somebody has started, because you see the first costal cartilage has been calcified and has caused some shadow. So, that has given some confusion. Could it be some disease in the chest, but as you can see very clearly, this is a costal cartilage calcification. And only problem arise, it is a bilaterally calcified, but sometimes what happens, there is a asymmetrical calcification, then sometimes it is being confused with tuberculosis. So, one has to be very careful. Now, this was the another gentleman who had suffered from tuberculosis in 1983, and he got treated for tuberculosis and got well. Now, after about 9-10 years, he developed recurrent hemoptysis, and you know that shadow has appeared in the right upper zone at the previous site of tuberculosis. And finally, we found that since you see that the rib, if you see very carefully, one or two, first, second ribs have been eaten away by this shadow, and when we further investigated, we did a CT guided biopsy, we found that this is adenocarcinoma of the lung. So, here you find that tuberculosis scar is converting into a lung cancer and what is known as scar cancer. Now, there is another lady which you find in the chest X-ray PA view, there is some shadow in the lower zones, very doubtful shadows. And then when we examine this, even in lateral view, you find that this shadow is coming in front of the sternum and it is entirely placed. And when we examine the lady, you find this is something, a very unusual mass-like structure over the sternum. And this, so what I am trying to say, many times in chest X-ray, we as a chest physician faced with the problem of shadow coming from outside the lung and causing shadow in the chest X-ray, creating lot of confusion about the diagnosis. Now, this is another gentleman who came to me with the complaints of fever and hemoptysis, and if you see the X-ray, X-ray appears within normal limit. And so, there was some suspicion that there might be some shadow behind the right clavicle. So, we got a lordotic view done, and in lordotic view you can clearly see that there are infiltrates, there are shadows in the right upper zone. And finally, it was proven and as tuberculosis, and patient was treated for tuberculosis and got well. This is another case where you find that lady started with fever and chest pain. And if you see the X-ray, it appears that within normal limit, but only positive finding was right dome of the diaphragm, it appears to be somewhat elevated. And we suspected right-sided infrapulmonary effusion, and we got right lateral decubitus view done, and you know fluid has shifted, fluid was aspirated, it was proven as tubercular, and patient was treated and got well. This is another case who presented again with fever and chest pain on the left side. And if you see the X-ray, although X-ray appears to be normal, except that the left dome of the diaphragm is higher up I have already told you in my X-ray teaching that left dome of diaphragm in about 5 to 9% of the cases may be at same level, even at higher level, this could be present in the normal people. So, but since he had the symptoms pertaining to chest disease in terms of fever, in terms of chest pain, so investigated this lady further and we found there is a infrapulmonary pleural effusion on the left side, and you can see fluid was aspirated, treated, proven to be tubercular, treated with anti-TB drugs, and you see after the treatment her diaphragm became normal. Now, this is another gentleman who came to me with this complaints of recurrent hemoptysis, and he was diagnosed as tuberculosis for 3 occasions and received anti-TB drugs without any response in terms of hemoptysis. So, he came to me. If you see his face, you find that one of the eyes has corneal opacity and he has smallpox marks. When I took the history that whether he suffered from some exanthematous fever, he said he suffered from smallpox during childhood and there was lot of respiratory complications after the smallpox, and he developed finally bronchiectasis. So, such type of cases are not very uncommon in India. Now, you see this shadow on the right middle and lower zone, there are some heterogeneous shadow where bronchovascular markings are very crowded, and then we got a CT thorax done which clearly has shown that there is evidence of bronchiectasis in middle and lower lobe. This is another patient who had recurrent hemoptysis, and if you see her X-ray, it appears practically within normal limits. Hardly anything is visible which can cause hemoptysis. So, we just to localize the lesion, we got lateral view done, but we could not get any finding. Then we got a lordotic view done because we suspected, because of some doubtful shadow in the right paracardiac area, we got lordotic view done, and we have already told you the out of 2 indications for the lordotic view, one indication is middle lobe collapse. If there is a middle lobe collapse, it neither on the PA view nor in the lateral view it will cast a shadow, but in lordotic view you typically get a triangular opacity in the right paracardiac area. So, this was diagnosed as a middle lobe collapse. This lady presented to me with complaints of recurrent bouts of moderate to massive hemoptysis, and she was given many courses of anti-TB drug. And when she was referred to me in 88, believe me, somebody wrote her the second line anti-TB drug. Although in 88 name of MDR-TB was not very common, but somebody suspected some drug resistance TB and he wrote second line anti-tubercular drug. But when she came to me with hemoptysis, we got some treatment, hemoptysis controlled, and if you see the X-ray carefully, you find there is a double hard border, means behind the hard border there is another hard border, and finally we suspected as left lower lobe collapse, and we find coarse crepitation in the left infrascapular area. So, we suspected bronchiectasis in the left lower lobe. At that time we used to perform bronchography. So, we did perform bronchography on the left side. So, we could find that left lower lobe is dilated, branches are dilated and they have come together. So, there is evidence of collapse with bronchiectatic changes inside, and this is the lateral view which has clearly shown that there is a dilated bronchus in the left lower lobe. So, she was diagnosed as bronchiectasis and she was since she had recurrent massive bouts of hemoptysis, so she underwent left lower lobe lobectomy and she became all right. This is another gentleman whose problem was that he again had a recurrent hemoptysis, and he has been a chronic smoker, but he has evidence of COPD, but that COPD is not usually being explaining what is the cause of recurrent hemoptysis. So, we investigated him further. If you see in this X-ray, you find some doubtful shadows retrocardiac area on the left side. So, we got CT thorax done, and high resolution CT thorax has shown a localized bronchiectatic changes in the left lower lobe. What I am trying to say, these are the hidden lesions, and you have to apply your mind. Physical examination in such cases are very important, and further investigations are required to prove the diagnosis. This is another lady who has come to as a case of COPD. As you see that she has cough, expectoration, breathlessness for last 3 to 5 years. She has been bidi smoker for 35 years, and already somebody gave her treatment for tuberculosis because of she had developed hemoptysis and chest pain. And we say that if patients of COPD develops some new sets of symptom, you must investigate, because she is already known case of COPD, but for last 1 year she had developed hemoptysis and chest pain. So, investigated her further. Chest X-ray now subsequently has shown there is some doubtful paratracheal shadow, and then we got CT thorax done, and CT thorax has shown there is a mass in the mediastinum. You can see emphysematous bulli, and you can also see there is evidence of pleural effusion on the right side. So, every symptoms can be explained, hemoptysis, chest pain, and ultimately we did bronchoscopy and transtracheal needle aspiration was done, and we reached to that mass, and that has shown that it was case of squamous cell carcinoma, and bone scan has also suggested skeletal metastasis in the sacrum. What I am trying to say that sometimes the shadows are hidden, and you know this patient, although the X-ray appears to be quite normal, but she was diagnosed as a stage 4 of lung cancer. This is another patient who had complaints of dry hacking cough and some breathlessness. So, X-ray, if you see carefully, there is hardly anything visible except that some bronchoalveolar markings appears to be more prominent in the middle and lower zones, but that cannot dictate the diagnosis. Since she had recurrent bouts of dry hacking cough, so and CT thorax has shown some nodular opacities, diffuse nodular opacities, and finally, when her TLC DLC was done, TLC eosinophil came out to be 48%. So, she was diagnosed as a case of tropical pulmonary eosinophilia, and a course of diethyl carbamazine for 3 weeks had made all the differences. She became asymptomatic, her chest X-ray and CT finally became normal. This is another patient, about 65-year-old female. She was non-smoker. She had cough and breathlessness for 5 months. Now, if somebody had breathlessness for 5 months, and then on examination, if clubbing was there, and the most striking finding in physical examination was bilateral basal inspiratory clefts. So, though X-ray shows some haziness in the both lower zone, especially in the left side, more on the left side. So, what I am trying to say, history was very typical. She had cough and breathlessness for last 5 months, and then she had clubbing, and then she had inspiratory bilateral basal crepes. That is very clearly indicating that she has interstitial lung disease. And if you see the spirometry was done, that has shown severe restrictive disorder, and you see the CT thorax, which has shown typically bibasilar subpleural findings, which favors towards the diagnosis of idiopathic pulmonary fibrosis. I mean, this is the last case possibly I am going to discuss in this session. She was a doctor, about 63-year-old female, presented with progressive breathlessness for last 1 month and along with dry cough. When I went into the treatment history, history is very important, even past history of treatment is very important. When I went into the treatment history, she has told me that she had suffered from adenocarcinoma colon, and she was given some chemotherapy in form of oxaliplatin, 5-FU and leucovorin for 6 cycles about 4 months ago. And her X-ray was not very contributory at that time. In October 2008, she went to some other doctor, and she was prescribed inhalers in the that probably she had some airway obstruction, but without any response. So, she came to me, we investigated her thoroughly. If you see, the PFT was, spirometry was done, and there was evidence of the restriction. FVC was about 66%, even PaO2 was very low, and if you see the CT picture, that shows very clearly that even there is some there is lot of honeycombing, there was lot of interstitial shadows, some ground glassing is also visible. So, we suspected as of pulmonary fibrosis, possibly induced by cytotoxic drug. So, it was a drug induced. ILD was, whenever we see ILD, always try to take history of drug intake. So, in this we have treated her with the help of steroids, and you see with the steroids she has improved. Her FVC came to 85%, oxygen saturation become very normal, and even X-ray and CT improved. So, not that every interstitial lung disease is very fatal. If the picture was somehow like an interstitial fibrosis, IPF like pattern, but since it was a drug induced, drug was already stopped, and a course of steroid has made all difference. This is another young boy who came to me, and his father was very nervous that, sir, whenever I show my child X-ray to any doctor, doctor become nervous. He says there is a lot of shadows in the chest X-ray, how your child is normal. So, that is why I came to you to know what is the situation of my child. When I saw the X-ray, I was also surprised, bilateral haziness is present, and if you see carefully, you find a small, very hard type of focus, they are small throughout the lung, and this case was diagnosed. If you see that this is the CT picture, small nodules of high density, and this was diagnosed as alveolar macrolithiasis. So, what I am trying to say, alveolar macrolithiasis is not very common condition, but when it comes to you, most of the patients are asymptomatic, X-ray is very abnormal, and this you can diagnose with very typical distribution of these nodules and their type of shadows. So, what I am trying to say, there is always a clinico-radiological dissociation in such type of conditions. Come to end of my presentation, what I am going to say to you, as a chest physician, we see lot of cases, sometimes shadow are from outside of the chest, sometimes shadow are from within the chest, different type of lesions. So, you take complete history, do the physical examination completely. Single X-ray will be useful. If the person has been, old X-rays has been done, please take care of them also. If it is not diagnosed, then go for other investigations like CT, like bronchoscopy, like relevant investigation to make the proper diagnosis.